Well, good morning, everybody. My name is Christoph Stremikis, and I'm the Director of the Market Analysis and Insight team at the California Healthcare Foundation. CHCF is an independent, nonprofit philanthropy dedicated to meaningful, measurable improvement in the healthcare delivery system in California. Today is an exciting day as we highlight another study in our Regional Market Report series. Our regional market reports are in-depth studies of 7 diverse areas that reflect the range of socioeconomic, care delivery, and financing conditions that we have here in the acute care delivery system in California. Len is principal at the Blue Sky Consulting Group and lead author of the Regional Market Report on the San Joaquin Valley. Len, can you unmute yourself, get your camera turned on, and kick things off for us?
So thanks again, everyone, for joining, and particularly the panelists for being here to speak about the San Joaquin Valley region after I finish my presentation. Great. Well, again, thanks everyone for attending this morning to our regional report on the San Joaquin Valley. It was fascinating to do, and I'm privileged to be here and presenting our findings. So as Christoph mentioned, there are 7 reports about diverse regional markets across California. This is the 4th report. 2 others were released recently, and there is one yet to come. I'd like to thank my colleague, James Paci, who did the research and wrote the report with me. And my consulting team colleagues include Katrina Connolly, Caroline Davis, Matt Newman, and Jill Joaquin, all of whom reported on other regions in California. So here are our panelists that Christoph mentioned. He'll introduce them again as we get to the panel section. So the San Joaquin Valley, we titled this, "Despite Poverty and Capacity Constraints, Healthcare Access Has Improved Over the Past 5 Years." And again, kudos to my colleague, James Paci. How did we undertake these market studies? We were trying to tell a story of how the region and its healthcare providers, financing, safety net, Medi-Cal beneficiaries and Medi-Cal plans has evolved over the past 5 years. We interviewed 23 regional leaders that represented health plans, hospitals, medical groups, county government, community leaders, and also advocates. There is a quantitative component to these studies. We looked at data for the region from the California Health Interview Survey, the US Census. We looked at data from the Office of Statewide Health Planning and Development for both clinics and hospitals. We looked at industry reports, journal articles, and news stories. And for the San Joaquin Valley, we relied predominantly on the Fresno Bee. As all of us have been working through and experiencing, the COVID-19 pandemic started a year ago. We added some questions to our interview protocol to address how providers were being impacted by COVID-19. It did not, however, become the predominant focus of our report. We wanted to stay connected to the 6 domains of interest, and we added another domain focused on the COVID-19 pandemic. I know this is a very busy slide. Just to give you some background on the San Joaquin Valley, the counties that we included in our study are Fresno, Kings, Madera, Mariposa, and Tulare. And those 5 counties are home to 1.8 million people. It's mostly a rural and agricultural area, which abuts the Sierras. But there are a few dense population centers, notably Fresno metro area. Compared to California overall, the San Joaquin Valley is much poorer. It's more Latinx. It's younger and almost twice as likely, residents there are almost twice as likely to be unemployed. So if you notice on the pie chart, as far as the Latinx community, it's almost 57% of the entire region is Latinx, compared to about 40% statewide. We looked at the California Health Interview Survey data, which are self-reported responses to questions about health, to understand how San Joaquin Valleys fare as far as their physical health. And in general, they have much poorer health status than Californians more broadly. It's Their health status is among the poorest in the state. The obesity rate, infant mortality rate are about 50% higher than rates statewide. As you'll see on table 2, there are higher rates of asthma, higher rates of diabetes, and the residents are more likely to report that they are in fair to poor health than Californians more broadly. And so these health and income disparities, as well as other socio-demographic factors, certainly contributed to a much worse COVID-19 pandemic in the Central Valley than in other places in California. We looked at health insurance coverage and how that has evolved over the past several years. And the San Joaquin Valley, 44% of residents are covered by Medi-Cal, which is a higher percentage than any of the other regions that we studied. About a third of the region's residents have private coverage, which is much less than the about 50% statewide who have private coverage. Just over 2% have coverage through Covered California, our state marketplace, which is lower than the 3% statewide. And as far as the Medi-Cal managed care model, the 4 of the 5 counties participate in a 2-plan model where you have one publicly run plan, which competes with a commercial plan, and CalViva, which is the local initiative for Fresno, Kings, and Madera counties, covers 70% of the more than 500,000 Medi-Cal enrollees in those 3 counties. And then Anthem Blue Cross serves as the commercial plan to serve the remainder of the Medi-Cal enrollees in those 3 counties. We looked at OSHPD data for both clinics and hospitals and did interviews with hospital CEOs or CFOs or vice presidents for population health to understand the sector. And hospitals mostly have been stable, although district hospitals have struggled over the past few years. There are 5 systems that dominate the region, Adventist Health, Community Medical Centers, Cahuilla Delta Medical Center, St. Agnes Medical Center, and Valley Children's Hospital, which is in Madera County. Compared to hospitals on average statewide, hospitals in the region have fewer beds and FTEs on average, lower operating expenses, and better average operating margin. And there's more detail in the 2 tables to the right. The financial status of most hospitals across the region improved since 2014, as you can see in table 7. There are 3 district hospitals, John C. Fremont, Cahuilla Delta, and Sierra View, which had operating margins below the regional average. So as I noted, district hospitals have not fared as well as other hospitals in the region. Notably, Tulare Regional Medical Center, which is a district hospital, closed due to bankruptcy in October 2017, and then reopened a year later under Adventist Health Management. Another district hospital in southeast Fresno County, Coalinga Regional Medical Center, also closed in 2018, and it did not reopen. There are 2 types of clinics that play very important roles in access in the region, federally qualified health centers and rural health centers. Both of which grew considerably since the last report was published in 2016. There are several large FQHC networks in which together accounted for nearly 2 million encounters or patient encounters in 2018. The number of FQHC sites in the region increased from 63 to 85 over 4 years between 2014 and 2018. And the number of encounters, patient encounters in FQHCs grew by 50%. That's encounters per capita in that same time period. And it's more than double the statewide average. And this indicator really tells you how important a role federally qualified health centers play in serving Medi-Cal and uninsured and other residents in the Valley. FQHCs have partnerships with hospitals, notably Camarena Health, which is in Madera County, and Family Healthcare Network, which is in Fresno and Tulare counties, have important partnerships with hospitals to provide outpatient care, to be there upon discharge, and also to refer patients for inpatient services. Rural health centers are also federally designated, and they must locate in non-urban areas. They also have a very large presence in the Valley. There are 82 of them in the region. So there are 85 FQHCs, 82 rural health centers. Half of the rural health centers are operated by hospitals, and half of those are administered by Adventist Health. And something that was noted in the report on the region 4 years ago or 5 years ago was that there was some competitive tension between rural health centers and FQHCs around, where they're locating. Are they rural? Are they urban? And there's some competition for Medi-Cal patients, and also for the prospective payment rates that the FQHCs and the RHCs receive. Generally, they're higher for RHCs because the cost structure for RHCs is hospital-based, which pushes their rate up a little bit, in some cases quite a bit higher than FQHC rates. Another takeaway from our interviews on RHCs and FQHCs is that both, of course, contribute tremendously to access to services, both for primary care, specialty care, and behavioral health services. While there has been improved access, this is in the context of provider shortages, which continue to pose access challenges. So the San Joaquin Valley, 92% of residents live in a health professional shortage area. And the physician to population ratios are well below the statewide averages, and they're among the lowest in the state. So if you look at table 10, you'll see physicians per 100,000 in the San Joaquin Valley is at 130 compared to 191 physicians per 100,000 population statewide. And for each of the physicians, you can see here for primary care, for specialists and psychiatrists, those ratios of physicians per 100,000 are all lower than their statewide averages and also the recommended supply from the federal government. So specialist shortages on the physician side include psychiatry, dermatology, optometry, pain management, and orthopedics. And in our interviews, we heard certainly about physician shortages, but we heard just as much or more about challenges attracting and retaining physician assistants, nurse practitioners, RNs, and behavioral health providers, notably licensed clinical social workers. On the bright side, there are programs and resources available to attract healthcare professionals to the San Joaquin Valley, and that includes both state and federal loan repayment programs. There's a UCSF Fresno training program for third and fourth year medical students and residents, many of whom remain in the area after their training. Fresno Unified and other school districts have workforce pipeline programs which encourage high school students and perhaps even junior high students to follow a pathway to a health occupation or a health profession. And the expansion of telehealth, which was really promoted and through the COVID-19 pandemic, has made some difference in improving access to services. Our studies focused on behavioral health services for the Medi-Cal population, and we found that behavioral health services have improved for Medi-Cal enrollees in the region, but there remain access challenges. So similar to self-reported health status, mental health residents report higher levels of mental distress than the statewide average, and the suicide rate is considerably higher than the California average. There is a serious shortage of psychiatric inpatient beds, although there is a new facility that will be built in Madera County that will have 128 inpatient psychiatric beds coming in just a couple of years, which will include 24 pediatric inpatient psychiatric beds. So our respondents and our interviewees noted that access to mental health services and substance use disorder services Medi-Cal enrollees has improved, although there remain gaps around workforce issues, which I mentioned previously. The Medi-Cal pilots and programs for whole person care and drug Medi-Cal organized delivery system have improved access to services, particularly to substance use disorder services. And county behavioral health organizations have been partnering with Medi-Cal managed care plans, FQHCs, RHCs, criminal justice agencies, and other county-based agencies to provide services to residents in the region. And there has also been an influx of federal and state grant dollars to the region, about $50 million, to address the issues of homeless services. And as I noted, we certainly paid attention to COVID-19 and how that was impacting the region. And we have metrics where we looked at before COVID and then mid-pandemic in October. Those were the last data that we had. And initially, there was a slow initial spread of COVID-19 through the valley, and then a much more rapid transmission through the summer and fall. And as everyone listening sadly knows well, the Central Valley, the San Joaquin Valley, has been hit quite hard by COVID-19. Both the cases per 100,000 and deaths per 100,000 have been much higher than other regions, and particularly hard hitting on communities of color. The unemployment rate was actually not changed very much compared to the statewide rate. And we believe that this is because there is a lot of essential employment in the Central Valley around agricultural and food processing and other essential services. Medi-Cal enrollment was up almost 3%, which was less than the statewide increase. And we attribute that to folks retaining their jobs, or perhaps had already been on Medi-Cal. And as I mentioned earlier, COVID has had a disproportionate impact on the Latinx community in San Joaquin Valley and other communities of color. As far as providers, as I noted, COVID-19 has catalyzed a very rapid adoption of telehealth, and as in other regions, and has mitigated the impact of not being able to do as many inpatient visits, or in-person visits, I should say. COVID-19 also inspired improved collaboration among healthcare providers, county public health, hospitals, and clinics. And the state and federal funds through the CARES Act and other funds have really helped to mitigate the impact on providers and service delivery. And at the end of each of these market reports, we look forward into the future based on what we discovered through our quantitative studies and through our interviews to kind of look ahead and ask questions about what should be tracked over the next 4 years and then studied 4 years from now. And here are the main areas where we thought it would be important to study and to continue to track. So first, how will expected state budget shortfalls driven by the pandemic affect Medi-Cal, which covers almost half of the region's residents? Will larger hospitals and health systems continue to perform well financially as they have over the past few years? Of course, COVID is impacting them now. Will the financial struggles of district hospitals spur more consolidation between hospitals? Will pressure for providers to take risk-based payment increase? And how will providers develop the infrastructure and data analytics to manage risk successfully? Will emerging partnerships among county mental health plans, managed care plans, and other county agencies be sustained? And will telehealth be integrated into the delivery of routine care after the pandemic and improve access to care for some services? And lastly, what will be the long-term impacts of the COVID-19 pandemic on the health and socioeconomic disparities in the San Joaquin Valley region? And I will hand it back I will stop sharing my screen, and I will hand it back to Christoph.
Thank you, Len. There's a lot of fascinating information and questions that you've raised there. And I'm really excited that we have such an esteemed panel of local leaders for their perspective on some of these challenges and opportunities that you've highlighted. Just as a reminder, each panelist now will provide about 4 or 5 minutes of remarks on any findings that were particularly surprising, anything that really resonated, or anything else that they'd like to highlight. Just as a brief reminder again to our audience, please feel free to type any questions for our panelists into the Q&A box. We've already got several that have come in, and please do feel free to keep them coming. So at this time, I'd like to turn things over to our first panelist, Dewan Utect. Dewan is Director of the Fresno County Behavioral Health Department. Dewan, can you unmute yourself, turn on your camera, and let us know, how do things look in the San Joaquin Valley from your perspective?
Well, first, I want to thank Lynn and the rest of the Blue Sky Consulting team, as well as the California Healthcare Foundation, for producing this really important report. And in this report, really highlighting the uniqueness of our valley and the high degree of poverty, as well as the incredible diversity that we have here, which does result the poverty in a lot of Medi-Cal in our region. And as a county behavioral health department, that is largely the population that we serve. And so we have seen, we certainly saw a great benefit from Medi-Cal expansion, but particularly for mild to moderate, as well as substance use disorders, we've really been rushing to keep up in terms of growing our delivery system. And, the way that behavioral health fits into the healthcare delivery system is very siloed and fragmented. And the system design is how we get our results. So that is something across the state that we're looking at in terms of the structure of the system and how do we improve the outcomes for the people that we serve by designing a better system. One of the things about the report that I did want to highlight, often I hear quoted that there's an inpatient bed shortage, and we have definitely seen a decline in the number of licensed beds across the state of California. But we have gaps throughout the continuum of care. And so, oftentimes, and we have a 16-bed adult inpatient facility, a psychiatric health facility here in Fresno, and it's full all the time. But some of the people who are in there are in that setting because the downstream beds are not available as well. So I really want to highlight that we have to really increase capacity throughout the system of care. Otherwise, we get those bottlenecks in emergency departments and crisis stabilization units, as well as inpatient units. And that's something in the governor's most recent budget. There are some funds in there for increasing capacity. And I know in Fresno County, at least, those will be funds that we hope to access. I also wanted to talk a little bit about COVID and the rapid shift to telehealth. If you had asked me 2 weeks before the state of emergency was declared how quickly we could move to telehealth, I would have told you it would take months, if not years. And we were really able to do it in just a week or two to deploy the resources and really be able to deliver telehealth services. And through the pandemic, that has enabled us to continue offering services and actually increase the number of services and the number of people that we're serving. We have kept inpatient service or in-person services, we'll say, for urgent care and crisis and some field-based services and inpatient, et cetera. But I do want to note that while we feel like we've been successful and that has greatly benefited the population we serve, we do know there's pockets of vulnerability. Individuals who either don't have the proper equipment to do telehealth, and for us, telehealth is video. We also offer telephone, or they're in an age range. Some of our youngest clients really need that in-person services, or they don't have access to the internet. And so as we move forward, we definitely see telehealth as an integral part of our services and an adjunct to some of our in-person services, but we'll have to overcome some of those barriers and or really tailor those in-person services for people that we serve whom really they can't get their needs met through telehealth. So that's going to be important as we move forward. The other thing about COVID is that we've all experienced the collective trauma of physical isolation and the uncertainties economically, and certainly the tragedy of the illness and death that COVID has created, which in some ways has really heightened the awareness of mental health and substance use disorder for all of us. And we're really hoping that stigma and discrimination that historically has existed and really caused people to not be as likely to seek services will help us in terms of normalizing the conversation about mental health and substance use disorder, and hopefully making it easier for people to access services. We also hope that it will help us as we work to build the workforce. Lynn really highlighted across behavioral health system of care, from psychiatrists to psychologists licensed clinical social workers, marriage family therapists, professional clinical counselors, and nursing staff, we have shortages. And the San Joaquin Valley has shortages beyond even what's in the state of California and beyond even what's in the nation. And so it's really important to us to focus on that. And we really need our workforce to look like the people we serve. We need a more diverse workforce. And so some of the ways that we're working on that is in partnership with UCSF. They are our psychiatry provider, and we hope to work with them to build fellowships. And we're also really, really expanding our services in schools. And our hope is that we kind of have, attack two things at once, and that is both getting services to kids at very, very young ages, well before they can develop more severe problems. And also by being in schools, hopefully make that a career that kids see as a bright future for them. And so workforce and our partnerships are super important as we move forward. We've heard a lot about partnerships, and that is how we have made it this far through the pandemic, is working with the network of community-based providers, our hospitals, our health plans, and such to get through this. And then two other things I'll just highlight very quickly. We have a huge housing shortage here in the Central Valley, and it is a big problem for us with the people we serve, particularly with our homeless population. We talk a lot about mental health and substance use disorder, and that's a real issue with homeless. But our lack of affordable housing is critically important in addressing that problem. And then really dealing with we need better data. We need to be a more data-driven industry. And I will highlight that our association is sponsoring AB 686 with Assemblymember Arambula around outcome and accountability. And so with that, I think probably my time's up.
Thank you so much, Dewan. That was perfect. Next, it's my great pleasure to introduce Paulo Soares. Paulo is the CEO of Camarena Health, a network of health centers in the San Joaquin Valley. Paulo, I see you've got your camera on. Can you unmute yourself and let us know how do things look from your perspective?
Yeah, thank you, Christoph. I appreciate the opportunity to share some comments here on the report. And yeah, great report. One of the things, especially from the perspective of the federally qualified health centers that I really appreciated in the report is not only speaking about the tremendous growth that federally qualified health centers has seen here in the San Joaquin Valley over the number of years, but really the role that they play in the delivery system. Because really over the last 5 to 10 years, we've seen more than just the physical growth of number of sites or patients being seen, but really federally qualified health centers have really developed into some complex organizations, far more than they were a decade ago. And some of that was highlighted in the report. I think some of the growing partnerships in the region are really going to pay dividends when we're trying to provide access and services to some of the populations that have those challenges. The report highlighted some of the hospital partnerships, and I think those are great. Like I said, I think 10 years ago, a lot of the health centers were just kind of these small family practice, clinics that didn't get a lot of attention. But as the Medi-Cal population grows tremendously in this region, and federally qualified health centers become, in some areas, the largest primary care providers. Those partnerships with the hospitals especially are very important, looking to help minimize ER utilization, lower readmission rates. And beyond the hospitals, we're also seeing some really strong partnerships between federally qualified health centers and health plans, especially some of the, when you look at the Medi-Cal managed care plans, there are hundreds of thousands of lives in those plans that are seeking care at health centers. And it just creates a great opportunity for some of these performance improvement and quality improvement plans to take place between the providers and the plans and the hospitals, and to really improve the overall health of these communities. Provider shortages was definitely an area that was mentioned in the report. And we've seen over the last couple of years, larger participation from community health centers and FQHCs in supporting some of our local residency programs, continuity clinics, allowing some of these physicians in training to step into the health center and provide care to our region, a large Medi-Cal population. And hopefully we're going to start seeing that pay some dividends in getting them to stay. We're also training a lot of physician assistants and nurse practitioners, working with local schools and schools even outside of the area that we can help and train them and attract them here and keep them here. And so I think overall, I think the last slide there, in the presentation asked a few questions. One that wasn't really on there that I think is worth kind of looking at and thinking about is kind of what will the role be for federally qualified health centers? How will it continue to develop and mature as we continue to move forward? And as these collaborations and partnerships continue to grow between the FQHCs, hospitals, health plans, schools, et cetera, to really help attack some of these challenges that the San Joaquin Valley is facing in really multiple aspects of the healthcare delivery system. So some of my thoughts on it, I thought it was a great report. It's great to kind of get the 10,000 foot view of healthcare in our region, and it's very well done. So thank you.
Thank you so much, Paula. That was great. Next up, we have Ryan Gates. Ryan is Vice President of Population Health Management at the Kauai Delta Health Care District. Ryan, I see you've got your camera on and yourself unmuted. Take things away.
Okay. Thanks again. I also want to thank Lynn and the foundation for allowing me to participate, not just on this publication, but on today's webinar. I found it very insightful, very accurate, and comprehensive for what's happening in our market. I think, in particular, in the last 12 months with COVID and its restrictions on conferences and just network opportunities, reports like this are just crucial for leadership to understand what's happening in our communities, in our market, and be able to drive better conversations around how we can collaborate around our community's needs. We all live very busy lives in healthcare leadership. And so, again, publications like this really help us connect the dots in terms of what's happening in our communities and who we should work with from other organizations to improve the health of our communities is our common mission. As a public healthcare district, Kauai Delta, we're able to provide a fairly comprehensive level of service from inpatient to ED to home health to hospice. And so kind of cradle to grave, we have a unique opportunity to see and care for patients through their lifetime of care, but also during those really critical acute episodes of care. So not only from the care model, but from the cost perspective and how we can engage. And we've been very blessed as a public entity now to be able to participate very deeply with DHCS in the state and the health plans in terms of just the large programs that are really providing resources to help us as hospital districts and as clinic systems to talk more openly about sustainable healthcare for our communities. And part of that, alternative payment model is the at-risk and global payment perspectives and contracts therein. While it's a very schizophrenic work when you're trying to maintain, financial operations amidst a fee-for-service construct and trying to carve a path towards the future of at-risk and alternative payment models. It's not easy, but it's sacred work, in my opinion. I don't think, I think the best answer in front of us in terms of the holistic care and need of the patient involves alternative contracting and therefore, to Paula's point, just demands more collaboration between our community partners, both the FQs and rurals and IPAs, and our health plans in terms of population health management. Again, when I assess, the lifespan of patients and their utilization of the healthcare system, you see that principle of the 5% consuming 50% of the resources. And And so we do a great job, I think, in the United States in terms of acute care and how we provide care through traumatic events and car wrecks and helicopters flying people into the hospital and OR and discharge, and all of that is world class. I think where we're challenged, I think this is largely because of kind of more fee-for-service contracts. We don't have, well-organized outpatient ICUs where patients with 5 diseases and 20 medications go and receive more intense services versus someone who's otherwise healthy. And so this gives us an opportunity again to put the care and the need of the patients and align that with the cost of care to those patients, and how can we financially sustain what we're doing based on their health and their decreased utilization and versus their sickness and their increased needs for utilization. So excited about the future and what that means. A report like this is good to hear other organizations, in our community working on at-risk contracts and just trying to build infrastructure to serve our community and around, especially those really vulnerable patient populations that are difficult to engage, and adherence to transportation, all the social determinants that really end up driving healthcare much more than just the medical care they receive. So I'm excited to participate in that. Thank you for the opportunity. And with that, I'll hand it back over to you, Christoph.
Thank you so much, Ryan. Lots of really interesting topics there. Finally, we're privileged to have Tom Hamilton. Tom is Regional Health Plan Officer of HealthNet, a national managed care organization that serves many of the region's Medi-Cal enrollees. Tom, can you unmute yourself, turn on your camera, and take things away?
Can you hear me okay?
We can.
So just before, when Ryan was talking, I was having some internet connection, so hopefully I'll have a stable internet here. So yeah, great to be here as well. Thank you for inviting me to participate in this conversation. Great job, Lynn, on the report. I think it was really spot on, like the other panelists have said. Just real quick, so HealthNet, I work for HealthNet as Christoph mentioned, and HealthNet is the actual the administrator for the CalViva program in Fresno, Kings, and Madera County. As part of Lynn's report, he mentioned that Fresno, Kings, and Madera are part of a 2-plan model, and CalViva is a local initiative, which is a county-sponsored health plan. So CalViva in turn subcontracts with HealthNet, and then HealthNet administers the program like we would in our other markets like Tulare County, where we have a direct contract with the state. I think the report that Lynn presented was really spot on. A lot of good information in there. One of the things that we really have a challenge with is the physician shortages, not only in primary care but in specialty care. As a health plan, we're always having to meet adequacy standards. It's kind of ironic. The DMHC requires health plans to meet a more stringent access to care standards than they do themselves when before the Medi-Cal managed care program came into existence. So it's really important that as a health plan, we're working with local providers, making sure we have appropriate access to care. I think the local residency programs that we have with UCSF and community medical centers, the St. Agnes and Children's Hospital affiliation with Stanford, and then the Qui Delta programs. Those are all critical pipelines to help replace the physicians that we know will be retiring in the coming years. So I see that as really, it's been an ongoing problem in the Valley, and trying to get those residency programs well established in the area. I think studies have shown that about 50% of the residents that will stay in a local area after they've gone through a residency program. So having those based here in the Valley is really important. So we need to keep supporting those kinds of programs. We're also pretty blessed in the Valley to have a network of very strong FQHCs and RHCs. Lynn mentioned that in the report as well. So we get about half of our access to care for the Medi-Cal program in this market through our FQHCs and RHCs. So they do provide really critical access to care. A lot of them employ PAs and nurse practitioners to provide even additional access to care. They have extended hours, which is really great to avoid ER usage. So they do play a very critical role. More and more of the FQHCs and RHCs are starting to bring specialists into their clinics to provide specialty access. It's challenging to get enough specialists to participate in the Medi-Cal program in the Valley. There aren't that many specialists in the first place, and they get really busy treating Medicare and commercial patients. So oftentimes they don't want to. They don't have enough room in their practice to take Medi-Cal. So sometimes when they practice through the FQHCs or the RHCs, they can just block out half a day a week, whatever, and they can see a lot of patients at one time and through the clinic, and make it really easy for them to do their part to serve the underserved. So it's a great way for the health plans and for the FQHCs and RHCs to create more access to care. The report also mentioned telehealth. I agree with Dewan that before the pandemic, we always talked about telehealth. It never really seemed to be a major initiative. It was always out there lingering, but it wasn't really very well adopted. Once the pandemic happened, we got our telehealth program up and running at HealthNet in about 3 or 4 weeks. So it was done very quickly. For the Medi-Cal program, we use a company called Babylon, which is a global-based tech company. They're doing this all around the world, and we've been using them very successfully throughout California for the Medi-Cal program. The one area that we aren't up and running yet is the CalViva market. We just got approved by the DMHC recently to bring the Babylon telehealth program into the CalViva market, but right now it's still undergoing review and approval from the Department of Healthcare Services. So we're hoping that will get approved soon, so we can bring that program to the market as well. It's a great app-based program. It has artificial intelligence. It has like symptom checkers. So one of the first things they did was they put in a symptom checker for COVID. So people could take a look at that, look at their symptoms, and see if they need to go to the doctor or to get a test. So it's a really dynamic program, and we think it's going to be used even after the pandemic's over. I think telehealth, once people get used to using it, it's just an easier way to access care, especially for primary care services. It's also great for behavioral health medicine, and there's been a real shortage in that across the whole Valley. And as Dewan mentioned, it's a great way to provide behavioral health support and services. And Babylon has been really trying to add more behavioral health specialists to their network so that we can have a broader access to behavioral health services as part of that program. So we're excited about that. And then finally, as Ryan mentioned, just the one of the things that I would say the managed care industry has evolved a lot in the last 10, 20 years, but one of the areas we still have a ways to go is just the coordination of care. It's still somewhat of a fragmented system, and the top 1 to 5% of the patients take up a high degree of the resources for the overall healthcare dollar. So treating things like diabetes, obesity, congestive heart failure, hypertension, making sure that the people that have the sickest conditions are being managed appropriately, so that we can prevent repeat usage of the ER. And when they get into the hospital, making sure that we have proper transitions of care, whether it's going into a home health setting, going into a skilled nursing facility setting. You need to have all the components of care available to you, and have the people that can help transition those members from one setting to another to make sure they get appropriate care at the right place at the right time. Otherwise, I think that was really most of my comments. I think it was a great report, and looking forward to answering any questions.
Thank you so much, Tom. Great job. And your internet just hung on just enough to get through that. Great. So we were lucky. At this point, I'd like to use the remaining time that we have here, about 10 or 15 minutes, for a general Q&A with the panel. We've got a lot of great questions that have come in over the hour. So I'd ask all of our panelists, please turn your cameras on and unmute yourself. And as a reminder to the audience, you can continue to put questions into the Q&A box, and we'll do our best to get to those. So my colleague, our Senior Communications Officer, Lisa Alaferis, is helping to moderate questions. Lisa, can you get us started with our first question here for the panel?
Yeah, we have a question about telehealth. Great to hear that telehealth was considered for access to care. But this person wants to know what challenges or barriers were raised by interviewees, both challenges and barriers that were experienced by providers and by patients attempting to access care.
Yeah, so I'd love to direct this actually to each member of our panelists if they've got perspective. So Dewan, I hate to put you on the spot first, but can you talk a little bit about what you're hearing in terms of patient and provider barriers around telehealth?
Yeah, for the persons that we serve, as I indicated earlier, not all of the people we serve have access to internet, so telehealth can be challenging. That's the video portion of telecare. And for some of the diagnoses or the services that we're providing, telehealth just doesn't work as well. We would prefer to see someone in person when they're in crisis. We also have a lot of individuals who are receiving injectable medications, they need lab draws, that type of thing. And so there are some services that simply aren't conducive to telehealth. But the technology end of things is partly where we have problems. We've also had individuals tell us they don't have a private location. They don't feel comfortable revealing confidential information in whatever setting they're in. They might be in a household with a lot of people or where they can't find a private room. And so that also can interfere with the ability for them to engage in telehealth. And as I indicated earlier, I think it's critically important that we understand where are the vulnerabilities in telehealth, what populations does it not work for, and particularly for behavioral health, even when it's working, there's going to be times when an in-person service is better for the person that we served. And so that's something that we are working through. We're actually working with our UCSF Fresno partners to do some research into it. And I think that's going to be critically important as we move forward.
Thank you, Dewan. Ryan, do you have any perspective or things you're hearing from your providers at the district hospital?
Yeah, no, absolutely. I think prior to COVID, some of the restrictions on the originating site rules, et cetera, for FQs and rural health clinics just made it prohibitive to really do telehealth well. That's patient centric. We were vetting platforms prior to COVID. I mean, literally like down to the last two finalists, and then COVID hit. And the biggest thing with the vendors was patient access. So, some of them require an email. You have to log in, get a password, get your email before you can access the telehealth platform. And that just won't work for us in our communities. So we needed something very simple and elegant. And so we went with a platform called Doxy.me that all you need is a smartphone, and it sends a text. You click on the link and it brings up the video component. So we propped that up in 72 hours after COVID hit. And that's what we've been on since. But praise God, we've been able to cut our teeth on that. And now we really know what we're looking for the long-term partner in that. And honestly, in the last 12 months, it's the vendors we were looking at prior have all, drastically changed their platforms, their technology in response to those needs. So that was the biggest thing for us, is how is our patient population going to be able to easily manipulate and access the platform to access their providers.
Thank you. Paulo, do you want to jump in on this? Do you have any perspective, what you're hearing from both clinicians and patients at your centers?
Yeah, absolutely. Definitely echo a little bit of both Dewan's and Ryan's experience. We're using the same platform, and for that, us as a little bit of a trial and error as well in terms of really finding something that was easily used and accessible by our patients. I'd say overall they love it. It's definitely one of those things where in some instances a little bit tough to go backwards, and when we're serving some very rural areas, we have patients in areas that we're serving in Eastern Madera County, up in the foothill and mountain communities, and allowing access through a telehealth modality is a great benefit for our patients. Again, being in some of those areas, internet can definitely be a challenge. The ability to shift to telephonic as part of that telehealth visit is a tremendous help in that. And so we're hoping that we are able to do that, because definitely the change in allowing us to bill for these services was a big impact in allowing us to do that. The other piece that was a little bit of a challenge when we started to work towards that is allowing patients to have the ability to do some self-monitoring at home. So when they're on the phone with a physician and they want to know what their blood pressure is, or O2 sats, something along those lines, where they just want a little bit more information about how that patient's doing right now and some of their vitals. And that was a challenge when patients didn't have the devices to do that. And so we've been able to work with some of our partners and put some of those in the hands of our patients, so that now when they're having that telehealth visit or that phone call, our providers are working with some more information and allowing that visit to be a little bit more meaningful and impactful. So there's been some small challenges that I think we've been able to work through successfully. And I think moving forward is definitely going to be a modality that our patients and providers are both really going to want to continue to use, because it definitely helps improve that much needed access to care.
Thank you so much. Just in the interest of time, I want to get to as many questions as we can. Lisa, can you give us serve up another one?
Yep. This one is about the economy. In anticipation of the economy coming back in 21-22, what will be the impact on Medi-Cal enrollment or the transition from Medi-Cal to traditional employer-based insurance health plans?
That is a great question, Tom. I hate to put you on the spot, but can you offer us an initial perspective on that one?
Sure, I'll give it a try. Yeah, I mean, it's hard to predict. I mean, I think with once the pandemic kind of gets behind us and the economy starts to rebound, naturally you'll see fewer people on Medi-Cal. The main reason Medi-Cal has grown in the last year is because the state told the counties not to go through the redetermination process. So people that maybe no longer qualified weren't having to go through and get requalified. So naturally the Medi-Cal membership grew because people weren't having to go back and be redetermined. So once the state starts to redetermine members' eligibility, you're going to see people start to drop off the Medi-Cal program. And hopefully that's because the economy is doing better and employers are hiring and our people are getting commercial insurance or other avenues for their health insurance. But I do think it will drop off once the economy rebounds.
Thank you so much. I just want to keep going here. Lisa, do you have another question for the panelists?
Yes, there's a question about the new inpatient psych facility. And I know, Dewan, that you answered this you very kindly typed in an answer. But if I'll let Christoph direct it, but if we could get some more information about that facility.
That would be great. Dewan, can you handle that one for us, and then maybe Len?
Yeah, Universal Health Services is an organization, and they are partnering with Valley Children's Hospital in Madera County to build a 128-bed facility. I think Lynn spoke earlier. I think there's something like 24 pediatric beds, and the rest are adult beds. We aren't party to that agreement or arrangement, but we do see it as adding additional resources to help where we're under-resourced. In Fresno County, we have a 16-bed inpatient adolescent and a 16-bed adult PUF that the county oversees, but the area, particularly for youth, is very under-resourced. And so we do see this as adding to the capacity statewide.
Thank you so much. Len, any additional color from the interviews to add to that?
I would just add, I would reiterate what Dewan said earlier about it's easy to focus on the increase in the number of beds, but there's also this downstream continuum of care and services that are also needed. So if someone were to thankfully be able to spend time in an inpatient unit, their care and recovery depends on what's downstream. And so there's also capacity challenges downstream that will remain.
Thank you. I'd take a moment to plug a California Healthcare Foundation report, kind of looking at this continuum in some different regions, and I believe that was published about a year or so ago. So that is up on our website if folks are interested. We are running very short on time, and there was a couple questions about data exchange, and so I want to ask all of our panelists for just some brief perspective on data exchange in the region. I might start with you, Ryan. The question that I would ask each panelist is, what are the challenges that you see with clinical data exchange right now in the region? Are you getting the data into the district hospital that you need and able to transmit that out to manage population health? And do you see any needs or opportunities for improvement to that system of data exchange?
Yeah, I think the need for data is insatiable. It has improved greatly. I think Tom and HealthNet, using the Coziva platform, we were using it prior. And so these kind of population health data set, independent platforms that can integrate in with our EMRs is really growing in cadence. Anthem also funded that interface with us as well. So we're getting much better in the last 12 to 24 months in terms of our relationships with the health plan partners. We were part of the Central Valley HIE collaborative, but that has just continued to struggle in terms of robust exchange of data. But right now, it's with our health plan partners in the state is where we're seeing the most success in terms of our data sharing agreements.
Thank you. Paulo, any thoughts on your the flow of data kind of into and out of your health centers and challenges and needs?
Yeah, so similar experience, I think, with what Ryan is describing, in that the data sharing with respect to our patients from the health plans has really improved dramatically in a short period of time, and I think that's very helpful when we're back to those partnerships and collaborations and really trying to improve the health outcomes of our patients. Having that data has been a tremendous asset for us internally as we put together our population health initiatives and quality improvement initiatives. Other data is a little bit more of a struggle. I think, as Ryan alluded to with the HIE. So really what we're having to do with our kind of hospital, partners is really just kind of several one-off, exchange relationships. And it's not a central, data bank, if you will. So it's, we have one system with one hospital, another with a different hospital as our patients are in and out of the ED or being discharged, and getting that information so that we can follow up. So it's pretty fragmented when you get to that point of, the continuity of care there with our patients, accessing hospitals in the area. So hopefully we can catch up in that area a little bit. Like I said, the health plan stuff has been great. It's been great strides in a short period of time, but we still struggle a little bit with the exchange of information with all the various hospitals in the area.
I would say the partnerships are growing, though, and the conversations are there. To Paul's point, I mean, Carrie Hydash and Family Health Network allowing us to have some view-only access and some alerts that can get sent on ED discharges, et cetera. So we're in collaborations, but it's kind of like with crayons right now, still in the disparate systems.
Appreciate the information and the metaphors there. So unfortunately, folks, our time is up. I could talk to you guys all afternoon. Two very quick things is, folks have asked, the report, the slides, the recording will all be available on our website. And second, please do take a minute again to our attendees. Please fill out the evaluation that's going to pop up on your screen. With that, thank you to our panelists. Thank you, Karen, Angie, Scott, everyone behind the scenes. And thank you to you in the audience for joining today. We're all finished. Have a great day, and we'll see you next time.